Greetings. Let me take you through this first lesson that is relevant for endoscopy technicians and nurses. This is about the anatomy of the esophagus. These are my acknowledgements. And today's learning objectives include identifying parts of the esophagus and describing the structure and function of each part of the esophagus. So as you know, when we eat food, it goes into the mouth and then to the pharynx. And pharynx has three different sections. The upper story is called nasopharynx. The middle section is called oropharynx. And then below that is the hypopharynx. At the hypopharynx, you have two paths. One path is to the airway or the trachea going through the larynx, and the other one that is posteriorly located going into the proximal esophagus. And then as we go down, mid-esophagus and distal esophagus. I mentioned about two words, proximal and distal. When you look at it, what is proximal? Proximal is the one that is closest to the mouth. And as we go down away from the mouth, it is distal. So this section is the proximal esophagus, and this section is the distal esophagus. It's also important to keep in mind the different measurements. When we do an endoscopy, we pass the scope from the mouth, and then as we go down the pharynx through the esophagus to reach the gastroesophageal junction and then enter into the stomach. By the time the endoscope reaches the junction between the esophagus and the stomach, it has to traverse at least 40 centimeters. And as you can see here, it takes about 15 centimeters to reach the upper esophageal sphincter. And then you go down to the proximal esophagus. And it's important to keep in mind the proximal esophagus is in the upper part of the chest and the lower part of the neck, and the trachea is in front of it. As you go further down in the mid esophagus, the trachea bifurcates into right and left, and you will see the heart in front of it. The heart is taken out from here in this diagram. And then as we go down the lower esophagus, the esophagus goes through an opening in the diaphragm called a hiatus before it enters the abdomen and joins the stomach. When you look at the muscular structure from the mouth, when you take a swallow, it is a voluntary movement. And from here all the way down the pharynx to the upper esophagus, these structures are made up of skeletal muscle that is responsible for voluntary action, like chewing and swallowing. And then as we go down, the smooth muscle becomes the predominant one. And in the lower esophagus, it is the main muscle, which works on its own in an involuntary fashion. Let us learn about the structure of the esophagus. As you can see here, this is the lumen of the esophagus. The typical size of an esophageal lumen in an adult is about 30 millimeters. That's the diameter of an adult esophagus. And if the diameter becomes smaller, we have problems with the swallowing, and we develop difficulty swallowing, otherwise known as dysphagia. The lining of the esophagus, the mucosa, is what is the innermost layer, and that sits on a cushion of a connective tissue that has lots of blood vessels, lymphatics, as well as nerves. And then a muscular layer or muscularis propria with an inner circular muscle and an outer longitudinal muscle. And this muscular layer is responsible for the contractions of the esophagus in the lower esophagus that leads to involuntary, smooth, coordinated contraction that propels the food down, otherwise known as peristaltic action. The outer layer is called the adventitia, that connects the esophagus to the surrounding structures and anchors it in place. When we do endoscopy, a typical endoscopist, as they come down the esophagus and enters the stomach, he has to go through the diaphragm, an opening in the diaphragm called the hiatus, and then make some measurements or calls out some measurements. The junction between the squamous lining of the esophagus and the columnar lining of the stomach is called the squamo-columnar junction. And another measurement that he calls out is the top of the gastric folds, where they end and where the tubular esophagus starts. That is the gastroesophageal junction. So these measurements are important to keep in mind when we talk about different conditions involving the esophagus. Esophageal mucosa, most of the esophagus is covered by squamous epithelium, and stomach is covered by columnar epithelium. And the columnar epithelium of the stomach and the squamous epithelium of the esophagus, where they join, is called squamo-columnar junction, otherwise referred as Z for zebra line. And these are things that are important to keep in mind. And if you look at the columnar epithelium, it is a single layer of columns of cells, rectangular cells. And as the stomach lining joins the esophageal lining and becomes the squamous lining, the squamous epithelium is not single layered. Instead, it is multi-layered. And the cells, instead of being columns, are round or flat like scales. And this is a squamous epithelium. And we will find out a little more about these issues later on. And let's go to the blood supply of the esophagus. Esophagus receives its blood supply from the aorta, right bronchial tree giving esophageal branches, and directly from the descending thoracic aorta as well. The esophagus especially the lower part of the esophagus, receives its blood supply from the celiac trunk, left gastric artery, and esophageal branches of left gastric artery, while the upper portion of the esophagus receives its blood supply from the inferior thyroid artery. So important to keep these things in mind from the point of how to manage a bleeding if it were to happen, and what an interventional radiologist does if there was bleeding by performing angiogram and finding the source of the bleeding. That's usually rare in the esophagus because it has lots of blood supply. Let us look at the venous drainage of the esophagus. Esophagus drains by way of esophageal veins, and they drain into the azygous vein to the superior vena cava. So that's one route. The lower end of the esophagus drains into the portal vein, goes to the liver, and from liver to the inferior vena cava. Inferior vena cava and superior vena cava drain into the heart. And this anatomy is important when you're looking at a patient with variceal bleeding, especially in somebody who has developed portal hypertension from cirrhosis of the liver. So we will talk about it when we come to those areas. Thank you.